Good morning, ladies and gentlemen. The topic of this week's lecture is cutaneous sarcoidosis as a part of a multi-system disease. Sarcoidosis. Sarcoidosis is a disease that is characterized by formation in all or several affected organs or tissue of epithelioid cell tubercles without caseation, although fibrinoid necrosis may be present at center of a few. But classically, these are non-caseating epithelioid cell granulomas. Main features. The most important features of sarcoidosis are as follows. Number one, the disease process is usually generalized. So if you are seeing cutaneous lesions, it does not mean that the disease is limited only to skin. The course is protracted and usually benign, though sometimes with dangerous and disabling complications. So it's a slowly progressive disease, does not have a rapid fiery course, but it does have disabling outcomes. The disease may affect any organ of the body and classically sparing the adrenal glands. Lymph nodes, lung, liver, spleen, skin, eye, small bone of hands and feet, and the salivary glands are most frequently affected organs. All the affected organs conform to the same histological appearance, that is, non-caseating naked epithelioid cell granulomas. Other changes present to a varying and inconstant degree, that is weakening of tuberculin test, increase in serum gamma globulin, and raised serum calcium levels. The CAVM test is positive in most cases. However, this test is no longer used. Epidemiology. The apparent increase in over last 40 years has been mainly due to better detection, especially by mass radiography. The disease appears to be most prevalent, more than 10 per 100,000 population in developed countries. Overall, sarcoidosis may be slightly more common in women than in men and usually present between 20 to 40 years and is rare in young children. So in contrast to tuberculosis, which is the disease with which sarcoidosis is frequently confused, TB is seen in poor people in lower middle class or poor class and in underdeveloped countries, while sarcoidosis is disease of affluent and rich and seen in mainly the developed countries. Etiology. Infectious agents. Many infectious agents have been put forward, but cultures are always negative and response to treatment is poor to those infections. So it is now considered to be a non-infectious disease. The contribution of any mycobacteria, for example, tuberculosis marinum, avium intracellulaire, in pathogenesis of sarcoidosis is unknown. Same is the case with fungi. Histoplasmosis and other fungi and viruses have also been excluded. Genetic and familial factors. Familial sarcoidosis is well recognized and occur more commonly than chance would predict. There is no consistent mode of inheritance, although a recessive pattern is more common. Studies with human leukocyte antigen have not clarified the matter further. So the genetic factors are still unproven. However, familial cases are seen. Interferon alpha therapy. More than 65 case reports, sarcoidosis had developed 15 days to 30 months after commencing interferon alpha treatment. 50% of cases have skin signs. It is suggested that interferon alpha might stimulate Th1 immune response that is thought to be involved in the pathogenesis of sarcoidosis. Histopathology. Histopathology of sarcoidosis is typical and cannot be missed. There are discrete, well-formed epithelioid cell granulomas. The granulomas are not merging with each other like we see in tuberculosis, and there is a sparse or mild inflammatory infiltrate surrounding the granulomas. Giant cells may be seen, and in most cases, the giant cells are foreign body type giant cells. The dermis is usually replaced with uniform circumscribed nests of non-caseating granulomas. And you can see again, there are multiple foreign body type giant cells which is seen in this view. Shaman bodies. Shaman bodies are not a common finding. However, they appear as shell-like calcium impregnated protein complexes, more in sarcoidosis, but can be seen in TB. Calcium salts may be the precursors. Birefringent particles are found in sarcoidosis. So these calcium-like deposits are seen within the giant cells. Then asteroid bodies. These are star-shaped eosinophilic structures again seen in the giant cells. They are actually the protein microtubules. So this slide shows some differences between sarcoidosis and tuberculosis as far as the histopathology is concerned. So in sarcoidosis, where we see monomorphic tubercles, well formed, but in tuberculosis, we see caseating tubercles. In sarcoidosis, the granulomas are discrete, sharply defined, but in tuberculosis, they are confluent and diffuse. So giant cells are usually sparse, but mainly foreign body in sarcoidosis and Langhans type in tuberculosis. Lymphocytes have a sparse cuffing in sarcoidosis, and the granulomas are generally called as the naked granulomas. But in TB, there is numerous and scattered lymphocytes. So inclusion bodies are seen in sarcoidosis, not seen in tuberculosis. And then on reticulin stain, fine and abundant around the tubercles while it is destroyed. So around the tuberculosis granulomas. No caseation is seen in sarcoidosis, but it is seen in tuberculosis. So here you can see the discrete granulomas of sarcoidosis in comparison with diffuse and merging granulomas of tuberculosis. Also see the sparse cuff of lymphocytes and dense lymphohistoplasmacytic infiltrate surrounding the granulomas in TB. So this is a mild kind of fibrinoid necrosis in sarcoidosis and intense caseating necrosis in tuberculosis. The two type of giant cells, foreign body type of giant cells are seen in sarcoidal reactions and Langhans type are seen in tuberculoid reactions. The differential diagnosis of sarcoidosis is mainly done on histology exclusion, but histology can be confirmatory in presence of typical clinical features. So tuberculosis can be differentiated by culture. If ZN is not very helpful, then fungal culture or fungal staining may be done. Tuberculoid leprosy can be differentiated by finding granulomas around the nerves, by doing S100 to define the nerves within the granulomas and doing a leprosy. Then Crohn and granulomatous cheilitis may also cause confusion. The histological appearance of Crohn and granulomatous cheilitis is almost like tuberculosis. There are diffuse merging granulomas with dense inflammatory infiltrate. Other differentials include the foreign body type giant cell reaction like silica, tattoo, mercury, chromium, beryllium, zirconium. So the foreign body giant cell reactions or foreign body granulomas have a similar appearance to sarcoidosis. Staging of the disease. Pulmonary sarcoidosis is classically divided into 4 stages on the basis of chest radiograph. Stage 0, no lung change. Stage 1, bilateral hilar lymphadenopathy. Stage 2, lymphadenopathy with pulmonary infiltrates. Stage 3, pulmonary infiltrates but no lymphadenopathy. And stage 4, irreversible pulmonary fibrosis and emphysema. This staging of disease is important because whenever you diagnose a case of cutaneous sarcoidosis, you have to investigate the patient in line of systemic disease. And the most frequently affected organ of the body is definitely the lungs. So typical bilateral hilar lymphadenopathy, you can see thick hilars here. Then in this case, you can see the fibrotic scarring of both lungs. Classification of sarcoidosis on the basis of degree of internal involvement and on type of skin lesions. So the early sarcoidosis where erythema nodosum and bilateral hilar lymphadenopathy is seen, and intermediate sarcoidosis when papular or nodular forms are seen on the body. Then late is the plaque, subcutaneous, or lupus perneum. However, this may be unreliable as prognosis most often depends upon the extent of the internal disease. So generally, erythema nodosum is considered as an early sarcoidosis and papular and nodular form as intermediate, and plaque, subcutaneous, or lupus pernio as late type of sarcoidosis. Systemic features. Since sarcoidosis is a multi-system disease, there are lots of systemic features associated. There will be marked lethargy, loss of weight, and generalized general malaise. There can be a dry cough, dyspnea, and chest pain. Bone and joint changes. So bone is also a frequently affected site. There is acute polyarthralgia and may accompany erythema nodosum. A more chronic polyarthralgia may appear late in the disease. Classically, they involve small bones of hands and feet. The most common change is lysis with bone cyst. So you can see these lytic lesions in first metacarpals. Cardiac involvement. Granulomatous infiltration of conducting system may lead to heart block, papillary muscle dysfunction, congestive cardiac failure, pericarditis, chest pain, arrhythmias, and even sudden death. Muscle involvement. Polymyositis and myopathy occur rarely. Random muscle biopsies in patients of sarcoidosis are positive in 50 to 80% of cases. Nerve system involvement, another important system. About 5% patients with sarcoidosis have nervous system involvement. They include optic nerve lesions, cranial nerve palsies, meningoencephalitis, multiple sclerosis-like changes, peripheral neuropathy, mononeuritis multiplex, and psychiatric changes. Facial nerve is frequently affected with or without Herefordshire syndrome. Ocular involvement. Another common site, eyes are involved in up to 25 to 50% of patients. So after lungs, eyes are the most commonly affected area and is usually the first feature in about 10% of patients. So the different ocular findings include uveitis. It includes both anterior and posterior uveitis, and iridocyclitis may be severe and recurrent. Iris nodules represent granulomatous infiltration in the iris. Then retinochoroiditis is usually occur in chronic uveitis. Conjunctivitis. Conjunctival nodules are common and are opaque, gray, slightly elevated lesion. The millet seed nodules involve the eyelid margins. So main involvement is anterior and posterior uveitis. Lacrimal glands may be involved and there is decreased lacrimal secretion and resulting in keratoconjunctivitis sicca. Sarcoidosis is one of the cause of Mikulicz syndrome, which is associated with bilateral swelling of lacrimal and salivary glands. Optic nerve may be involved as a part of widespread involvement of cranial nervous system or as a unilateral retrobulbar disease. Orbital involvement, if the bone of orbit is involved, then it may result in unilateral proptosis. There are certain syndromes which are associated with ocular findings. And these include Lofgren syndrome. The Lofgren syndrome comprises of erythema nodosum, bilateral hilar lymphadenopathy, and acute iridocyclitis, and it is usually self-limited. Then Herefordshire syndrome. This includes uveitis, parotid gland involvement, fever, cranial nerve palsies, usually of facial nerve, and keratoconjunctivitis sicca with parotid and lacrimal gland involvement and enlargement. Lupus pernio, chronic iridocyclitis, bone cyst, and pulmonary fibrosis is another complex which is involved in sarcoidosis. Pulmonary and upper respiratory changes. Pulmonary changes dominate the later stages of disease, and progressive diminution of respiratory function is the most common cause of incapacity. Renal involvement. Symptoms are rare, but scattered granulomas can be found at autopsy in 40% of patients. Renal failure may be secondary to granulomatous invasion or to hypercalcemia. Reticular endothelial system involvement. Lymph node seen enlarged in 50% of patients. And in lungs, you can also see the first changes is the hilar lymphadenopathy. So the lymph nodes are also seen in other regions. Enlarged spleen is felt in 15% of cases. And liver granulomas are seen in 63 to 87% of patients, although liver is only palpable in about 20%. Hypercalcemia and hypercalciuria. The frequency of hypercalcemia varies greatly, but it is less common than hypercalciuria. Persistent hypercalcemia is manifest clinically as polyuria, nocturia, and polydipsia. Now, our favorite topic, that is sarcoidosis of the skin. Between 20 to 35% of patients with systemic sarcoidosis, they present as skin lesions. But cutaneous sarcoidosis can also occur without systemic disease, which is although rare. Finally, the extent of any cutaneous lesion does not correlate with the extent of the systemic disease. But another thing which is important when sarcoidosis come on the skin is, it is very become easy to diagnose the systemic disease, because usually our areas on the skin are accessible and can be biopsied easily. So many a times the dermatologist help in giving the diagnosis to the medical specialists. The features of specific cutaneous lesions arise from a dense accumulation of epithelioid cell granuloma in the dermis. So all the cutaneous findings except erythema nodosum present with typical sarcoidal granuloma. Erythema nodosum present as septal paniculitis. The lesion of sarcoidosis is generally recognizable as nodules or plaque. And there is no typical distribution and can occur at the extensor aspects of the limb and rarely the trunk. Angiolipoid forms. It affects women predominantly, and the site is the bridge of nose. They are soft and hemispherical, well-marked, orange-red or more livid hue than other forms. There is little tendency to spontaneous resolution. Annular form occur mainly in a chronic stage, formed by the peripheral evolution and central clearing, and particularly seen on the forehead, face, and neck. Erythema nodosum, as I've explained, it is septal paniculitis, is one of the reaction of sarcoidosis systemically, occur in young women, and signal an early and benign variant of sarcoidosis, usually associated with bilateral hilar lymphadenopathy, and have a tendency to involute spontaneously, and most cases resolve within 2 years. Lupus permi. It is mainly seen in older patients and twice as common in women. There is large bluish red, dusky, violaceous infiltrated plaques occurring symmetrically on the nose, cheek, ear, finger, hand, and toes. Lesions feel soft, doughy, or indurated. Ulceration rarely occur, but there is never gross mutilation. It tends to be associated with systemic features, persists for more than 2 years, and seldom resolves. Nodular forms. Usually the lesions are more than 5 millimeter, single or relatively few, reddish or red or yellowish red, violaceous, purplish, brown, soft, firm nodules. Affected sites are proximal limb, trunk, and face. Then papular or small nodular lesions, less than between 1 to 5 millimeter in size, hemispherical, orange or yellowish brown. Only few lesions or several hundreds may appear. If probed with needle, they feel firm. In general, the papular forms carry favorable prognosis. Then plaque forms involve chiefly limb, shoulder, buttocks, and thighs. Lesions are diffuse, irregular shape, having crescentric or serpiginous outline resembling tertiary syphilis, but they are persistent. And no gross mutilation. Scar sarcoidosis. Sarcoidosis appear in a scar, may be the only cutaneous sign of the disease. A long-standing scar, often on knee, become inflamed and infiltrated, giving a resemblance to keloid, but lesions do not itch. Scar sarcoidosis occur in three situations. In acute eruptive phase, in scars of biopsies taken at that time, at any later stage, with exacerbation of systemic disease may be preceded by this warning sign. And at the inoculation site, for example, after venipuncture, BCG or a tuberculin test. Subcutaneous sarcoidosis. This is a rare form and present as tender and painless persistent nodule, most often on extremities in middle age per patient, usually women. Systemic involvement is present and spontaneous resolution can occur. Then there are several unusual forms of sarcoidosis. And these are usually not associated with typical sarcoidal granulomas on histology. So alopecia is associated with sarcoidosis. Atrophic forms are seen on legs and demi-generalized with ulceration. Erythrodermic sarcoidosis, red scaly patches extend and merge into infiltrated brown-red sheets. Hypopigmentation, macular hypopigmented areas around the central indurated lesion. The two main differential diagnoses are leprosy and post-inflammatory hypopigmentation, idiopathic gutted hypomelanosis, and pityriasis lichenoides chronicus. Condition does not respond to corticosteroid but may repigment after prolonged psoralen or UVA therapy. Ichthyosiform sarcoidosis. So one of the cause of acquired ichthysis is sarcoidosis, seen on lower leg as large, thick, polygonal adherent scales, and may not overlie a dark red papule or nodule. Almost all patients with ichthyosic sarcoidosis have systemic involvement. Lichenoid forms resembling lichen planus or lichen sclerosorum, and tuberculin test is negative. Course is indolent and histology is characteristic. Mucosal involvement. Nasal mucosa is often affected in lupus pernio. Nasal bone may be involved and nasal cartilage may collapse. Nail involvement. The nails are thick, opacified. There is fragility, layering, convexities, longitudinal ridging, pitting, atrophy, nail loss, pterygium, red-brown discoloration. So almost all the findings of nail involvement are there in sarcoidosis. Skin lesions in children. Although sarcoidosis is uncommon in children, the lesions commonly comprise of maculopapules, confluent plaques, or eczematous lesions. Chest radiograph is often normal. The Blau syndrome is an asymptomatic red-brown papules on face, trunk, and limbs associated with arthritis and ocular disease with mutation in NOD2 gene. Ulcerated sarcoidosis, a rare presentation. Ulcer develop most often on leg and can be punched out. Granuloma may be of necrotizing type with caseation or minimal fibroid necrosis. So this is always a difficult diagnosis because the histological picture is also not very consistent with sarcoidosis. Verrucous forms. Papular lesions may progress to crusted or verrucous lesions and may mimic halogen eruptions, fungal infection, or tuberculosis. Now the course and prognosis. The prognosis is difficult to assess. It is generally better in female and those with less severe pulmonary disease at the onset, and patient with positive tuberculin test and normal globulin levels. HLA-B8 is associated with tendency to spontaneous resolution. Only a small portion of those with pulmonary stage 2 and beyond resolve spontaneously. Despite of corticosteroid therapy, half the patient continue to have abnormal respiratory function. So even the corticosteroid therapy is not 100% effective. Most types of cutaneous sarcoidosis occur in subacute or chronic forms, and their course is usually prolonged. Lupus pernio is especially persistent and often accompanied by involvement of other organs. Mortality in sarcoidosis is at 3 to 6% and is mainly due to cardiac or renal involvement, and rarely to progressive pulmonary disease. Investigation. The most important single criterion is finding of typical granulomatous histology. So biopsy is the foremost investigation since it involves several organs and allows clinician to select a biopsy site best suited for the individual patient. The dermatologist has an advantage of dealing with a site that is easily accessible for a biopsy. KVM test. This test is of historic interest because we are no more doing this test, but you should be aware of how the test was used to be performed. So it was described some 50 years back. The test depends on ability of sarcoidal tissue, usually from spleen, to evoke an epithelioid cell granulomas when injected intradermally into a patient of sarcoidosis. The forearm is injected intradermally with 0.1 to 0.2 ml of shaken antigen using a 1 ml tuberculin syringe. The positive reaction is a papule, usually appearing 2 to 3 weeks, and is best excised at 6 weeks for typical histology. Radiograph. Chest radiograph should be taken in all cases, no matter what is the clinical presentation. In addition to the bilateral hilar lymphadenopathy, which is the 4-bar sign of sarcoidosis, the most common findings are widespread small nodules at the bronchovascular and subpleural distribution. Thoracic high-resolution CT scan is not indicated when chest radiograph is typical, but is useful in patients with atypical radiological findings. PET scan with 18-fluorodeoxyglucose. It is more sensitive than 67 gallium scan for assessing the activity and extension of sarcoidosis. Pulmonary function test revealed decreased forced vital capacity and diffusing capacity for carbon monoxide. Advanced pulmonary fibrosis may cause respiratory distortion and decreased forced expiratory rate volume in 1 second, called as FEV1. Hand radiographs show cystic changes, as I have already shown in one of the pictures. Sputum should be examined and cultured for acid-fast bacilli, which should be negative. Tuberculin test is negative in more than 80% of patients. ESR is usually raised in active phase. Hypergammaglobulinemia occur in over half of the chronic cases, but is not of proven diagnosis or prognosis. Serum calcium is usually increased and may lead to chronic renal failure. Angiotensin-converting enzyme is produced by sarcoidal granuloma and is raised in more than 60% of patients. Other markers are lysozyme, beta-2 microglobulin, neopterin, collagenase and fibronectin levels, intracellular addition molecules, ICAM1, hydroxyprolinuria, and radioactive gallium-67 uptake. Diagnostic criteria. The diagnosis of sarcoidosis is based on mainly 3 things: a compatible clinical and radiological picture, non-caseating granulomas on biopsy. So the most common biopsies are transbronchial, skin, and peripheral lymph nodes, negative culture for mycobacteria and fungus, and exclusion of other granulomatous disease. So a compatible clinical and radiological finding, a positive skin biopsy, and negative culture for infections, and excluding other granulomatous histologies. When clinical and radiological findings are not typical, it is advisable to perform not 1 but 2 biopsies, and that should be positive for diagnosis. So the recommended basic assessment of patient with sarcoidosis include a history that includes the occupational and environmental exposure, then physical examination of the patient, ophthalmological examination, slit lamp and with an ophthalmoscope, chest radiograph, standard hematological and biochemical profiles that include urine and serum calcium level, hepatic enzymes, renal function, and serum angioconverting enzyme level. ECG is performed to exclude the heart involvement, pulmonary function test, tuberculin test, and biopsies, and including for histopathology and culture studies. So treatment. The most frequent indications of systemic treatment include severe pulmonary disease, progressive or persistent parenchymal lung disease after 2 years, posterior ocular disease or anterior disease not responding to local steroids, persistent fever and weight loss, liver disease with significant dysfunction or hepatosplenomegaly, disfiguring skin disease, nervous system involvement, hypercalcemia, myocardial disease, myopathies or myositis, thrombocytopenia, and other significant organ involvement, especially the kidneys. A major determinant is the degree to which patients' normal life is disrupted by the disease, but objective measurements such as pulmonary function test may be more valuable way of monitoring therapy than the symptoms alone. In a skin clinic, any decision about use of systemic therapy must be taken into account the seriousness of accompanying internal involvement and natural history of particular type of skin lesion. Papular lesions, for example, are likely to fade without treatment, whereas lupus pernio is not. So starting from the topical therapy, high potency topical steroids and interlesional steroid are the first line topical therapy. Tacrolimus, which inhibit the production of Th1 cytokines and tumor necrotic factor alpha by T cells, is reported to be beneficial. Then we can go for cryotherapy and radiotherapy, and PUA therapy is successfully used in hypopigmented and erythrodermic form of sarcoidosis. Systemic therapy first line. The first line therapy is no doubt corticosteroids, which are usually given in relatively high dose, that is 30 to 40 mg, and tapered over the period of several weeks to lower maintenance dose of possibly 15 mg on alternate days. Length of course of treatment vary, but is usually 6 months. Intravenous pulse methylprednisolone, for example, 1 gram per week for 8 weeks in those with severe neurological disease. It is important to discuss osteoporosis here, as it is multifactorial in sarcoidosis, and all patients on chronic corticosteroids should have a baseline bone density studies. For patients without hypercalcemia or nephrolithiasis, oral calcium supplement may be used, but the addition of vitamin D is less clear-cut. Calcium levels should be checked in summer months to detect hypercalcemia. Bisphosphonate have been shown to be useful in treating corticosteroid-induced osteoporosis in sarcoidosis patients. The second-line drugs used in sarcoidosis are 3: antimalarials, methotrexate, and tetracyclines. Antimalarial drug used mainly is hydroxychloroquine, 200 to 400 milligram daily, and is the most prescribed drug among the most prescribed drugs. It is useful in chronic cutaneous lesions and can be used as corticosteroid-sparing agent in severe cases. Hydroxychloroquine has less risk of retinopathy, but eye evaluation should be done after every 6 to 12 months. Methotrexate is most widely studied non-steroidal therapy for systemic sarcoidosis. Overall response rate is around 80% for skin lesions, and it is useful both for pulmonary and cutaneous sarcoidosis. Minocycline 100 mg twice daily achieve complete resolution of cutaneous lesions in 8 out of 12 patients. However, poor response is seen in lupus pernio patients. It is proposed therapeutic strategy to include to start the treatment with minocycline for 3 months. If response is unsatisfactory, then it replaced with hydroxychloroquine. Hydroxychloroquine may be added. And if it is not even responsive, then methotrexate can be added in the regimen. Third line treatment is mainly biological agents. Tumor necrotic factor inhibitors infliximab is used in unresponsive cutaneous sarcoidosis, including lupus pernio. And there is a report of successful use with adalimumab. Etanercept is generally not recommended. Anti-T cell agent alphacept is described to beneficial in lupus pernio. There is a list of other systemic treatments which is rarely used. They include isotretinoin, mycophenolate, allopurinol, pentoxifylline, tacrolimus, fumaric acid ester, trinelast, apremilast, chlorambucil, lifulamide, and thalidomide, which has multiple effects, including blockade of tumor necrotic factor alpha, and is reported to be effective in patients who are unresponsive to other treatments. are laser ultraviolet radiations and photodynamic therapy. Lupus perneos seen to improve with carbon dioxide laser. UVA 340 to 440 nanometer is effective in forehead plaques of sarcoidosis. Use of photodynamic therapy can also be considered. Surgical treatment or radiotherapy in rare cases. So this ends today's lecture, and I hope this lecture would be beneficial to you for your practice. I thank you all for a patient listening and see you next week for another edition of my lecture. Goodbye and have a good day.